This is Duke University.
On behalf of the Fuqua School of Business, thanks to our wonderful alumni for joining this session, and I look forward to a very interesting conversation with all of you. I am joined by Rick Staelin, who is actually the person who is responsible for hiring me. And for those of you who don't know me, I'm Bill Boulding. I'm the dean of the school. So Rick gets all the blame for the decision to bring me here in the first place. He was the dean of the faculty at that time and was actively involved in recruiting me. Rick and I have developed a very interesting collaboration over the years that began with running together. And on our runs, we would invariably talk about Duke basketball. And after I had shamed Rick into knowing that my knowledge was superior in this domain, we would turn to research topics.
Which, by the way, is I'm superior on.
So we have been great research collaborators over an extended period of time, and in recent years we've brought our research into the health domain, connecting some of our previous work on how it is that people form judgments of quality and satisfaction with respect to services, specifically into the area of health, which has some very unique aspects. So Rick, if you could, would you just talk a little bit about what we've done in this particular instance, and then we can tee things up for questions. We've had some questions submitted in advance from people, and we have had all minutes to review some of these questions. You can also tweet in your questions using the hashtag Fuqua alumni, and we'll address as many questions as we possibly can in this session. But with that, Rick, if you could take the podium.
We had a 13-minute video where we talked about these concepts, but if I had to give a 2-minute elevator speech, so to speak, I think our basic concept is that the provision of medical care really can be viewed as a service, and therefore as a service we worry about the co-production. And what we mean by that is that you really need a good interchange between the service provider and the service recipient to make the service a good service. So the basic concept then is that the patient actually knows certain things that the doctor doesn't know, and therefore a good communication between the two is very useful. If you want to think about measuring quality, right now HCAHPS measures quality, the medical profession measures quality on objective measures, clinical performance. And those are very good measures and very useful because it shows how the doctor is performing the task that should be performed. Unfortunately, that only captures one aspect of the total service provision. And the patient is providing softer knowledge, softer information about the communication, about things that are not measured, like whether the medication is given on time, whether they really understood the discharge instructions. And we find that by combining the two sources of information, namely the objective measures and the patient satisfaction measures, sometimes called patient experience measures, we get a better predictor of the service, the total service that's provided, and therefore the outcome, namely mortality rates or readmission rates.
Okay. So as I noted, we have some questions in hand, and so let me go to the first question, which is really more of an observation about what's happening in South Korea, where in South Korea the government is becoming very active in collecting data about patient satisfaction for the nation's big hospitals. and that they're actually collecting these data through official surveys, patient-based surveys, as well as for those of you who remember your marketing, mystery shopper style research, which is very interesting, that you have patients entering into the process who are collecting data explicitly as a part of their job. And so these are being combined with objective measures in order to rank these hospitals, and the result is that patients have better information on multiple dimensions. So Rick, it's not really a question, but do you want to comment on those observations about what's happening in South Korea?
Well, I think it's very interesting, and it is intriguing because I think we can use this as a source of data for our work. I was not aware of the fact that Korea was collecting that information, and maybe we could push forward. The person who sent this in was Sung-Young Kim, who was our doctoral student, so I'm sure that we will be in contact with Sung-Young. Hopefully he's online now. So.
Yeah, and I think it also highlights that that this is a global phenomenon. This is not something that is only of relevance in the U.S. And as a business school where we do have a commitment to making a difference in the world and tackling the fundamental challenges in the world, this is an issue that crosses borders. So moving to the next question, which is from Chris Adams, who is a Gemba graduate from the class of 2011. He has some specific questions about the data collection, and really two different questions from Chris. One is the tool set that you're using to collect data from email and smartphone sources coming from Biveris. And so, Rick, do you want to comment on that particular question?
The data that we use is not coming from Biveris, although Biveris is an organization that's collecting information. Let me just say that could be very useful for our research. Our research right now is based upon general patient satisfaction data, which is not linked specifically to the service provider. So we have a collection of patients who report on their satisfaction with their experience that's associated with a particular hospital. But we do not know who the service provider was for those particular patients. In the future, we see great potential in linking the patient with the service provider. And that can only be done when you know the identity of the patient who fills out the survey and then can hook it up with medical records. There is a firm that is Duke-based that is doing this now, based actually on our research that we reported. And their approach is to collect patient satisfaction data via a smartphone. And that data would be available within 24 hours, and the identity of the patient would be linked there, and you could link it up with the service provider who provided the information of the service. And so we see great potential in this, but we have not used that data yet.
Yeah. So that actually leads to the second question, which is, do you think what you described, which is using the smartphone response, is more efficacious than traditional surveying via telephone, even if those calls are going out within the same time frame and you get the same kind of response rate?
Yeah, well, I guess the question is the definition of efficacious. I think it's going to be less cost efficient to have someone on the telephone versus doing it by email or a smartphone. Also, there's an issue that I wonder about the response rate. If you think about all the surveys we get and how often people are not willing to answer surveys on the telephone, and there's a difficulty of landline versus cell phones, etc. I think that it would be very difficult to match the efficiency that you get with a smartphone and email versus a telephone response. So I guess my answer is I think the Biveris solution is a really good solution.
Okay. So there's another submission here, which is more of an observation than really a question, which is it talks about the difference between kind of a science-based approach to patient care and behaviors that reflect humanism, such as empathy, respect, caring, integrity, and so on. And so I think that there's an implicit question here which has to do with does that latter category matter as much as the science-based information? And certainly the results of our research indicate that it does matter quite a bit, and that one of the things that we talk about quite often is that when people think of patient satisfaction, they often think about having balloons and clowns and so on that generate happiness in some fashion. But in our research, what we really focus on are these dimensions that do relate to things like responsiveness, the ability to engage in a dialogue with the care providers in a way that you get diagnostic information about the appropriate kind of care. And so coming back to Rick's comment about the co-production. And so we think that that is actually at the core of why it is we find the significant effect of what's being called here humanism, in addition to the traditional scientific or evidence-based medicine standards. Now, there's another question that relates to that, and it comes from Randy Bollinger, who is a Weekend 97 graduate, who is someone who has been an abdominal organ transplant surgeon for almost 30 years. And he gives the observation that patient satisfaction depends much more on the graft function than on provider humanism. And so, very much related to the previous observation or question, that empathy, respect, caring, and compassion were near universal traits of the medical team that cared for these challenging organ failure patients. However, not all patients were satisfied. And what Randy or Dr. Bollinger goes on to say is that if you had excellent transplant function, you had satisfied patients, and if you had poor transplant function, dissatisfied patients. And so this is a very interesting observation, and not one that is inconsistent with our findings. And what's interesting is that in the surgical domain, first of all, we have to be careful that we haven't gone into all surgical domains, that we've looked at pneumonia, heart failure, heart attack in terms of the presenting clinical conditions. But after we had published our most recent paper in the New England Journal, I was actually approached by a surgeon, colorectal surgeon, who said that surgery is the last bastion for saying what we really need to do is make sure that we've figured out the right way to operate on the patient, make sure we have the successful conclusion of the surgery, and so we need to do the right things on the table, and that there's not a lot of view that the patient interaction, many patients asleep most of the times in surgery, is of real value in the setting. And this surgeon said, I disagree with the perspective of my colleagues, and has put a protocol into place where there is significant patient interaction pre and post surgery. And this is all being done where there's not, the person approached us essentially to say, would you please get involved with us to collect the data to make this systematic case that there is value in terms of the patient information that leads to better outcomes. And what was interesting was what the surgeon reported to me is that after having put this protocol into place, that the hospital administrators who are tracking the cost of procedures approached the surgical team and said, what are you doing, because you've actually reduced the cost of each patient in going through these procedures by a significant amount of money. And if we look pre and post, the outcomes are better in terms of reduced infection or reinfection after surgery. And so a series of clinical indicators that suggest that that indirectly there would be significant cost savings as well through reduced readmission. And so we do believe that while we don't have the evidence in hand right now, that again there is a role pre and post, and even in a surgery environment, where the patient can supply information that may be of relevance to make sure that the procedure is more effectively conducted. And so there is it's not that we think that surgeons that need to be more respectful or more empathetic or anything like that, but that there is actually information that enters into the process in an effective manner.
And following up on that, it's not just the interaction between the doctor and the patient in terms of the co-production of the patient supplying more information, but it's also making sure that the patient understands the information that's given to them, or that someone in the family does, to make sure then that procedures that happen after the surgery or after whatever service is provided are carried forward correctly. And that's where the readmission rates are so important, and where we find really very large number of people are being readmitted after being discharged. The number is somewhere in the order of 20%, which is a huge cost. And if we can reduce that cost, we can provide better medical care.
So we've now been getting some questions that are being submitted live, and so this will be even more interesting for Rick to respond to these questions. But this one is actually one that is a very astute question and very important in our research, which is, the question is from Amy Katch. And the question is, why was there no reference to not being able to document patient satisfaction of patients not able to communicate, and in other words, deceased or otherwise, and that impact? And so this is actually an important part of our research. So Rick, do you want to comment on that?
Clearly, when we do mortality studies, those that die, which is about 5%, we never get a response from them. We thought about the issues and how it biases our results. If anything, these patients are going to be less satisfied by definition, and therefore we thought through the bias. There's no good way to survey them, and so I don't know how we get that input other than to think about the fact that we might be at a family member. But from a research point of view, the bias is in the opposite direction of what we're reporting, and so we would think these people would be less satisfied and therefore not more satisfied.
Right, and there's another dimension of this, which is that our analysis is not actually at the patient level. It's at the level of the hospital unit. And so we're collecting data which is representative of the hospital's quality of care from a patient point of view, and we have data from the hospital with respect to the mortality that they're experiencing for these presenting clinical conditions. And so we're looking at those two sets of data, and that allows us to make inferences about that relationship. Now, as Rick alluded to earlier, ultimately we think we do need to get to the patient level,
right,
and connect the patient experience and the patient outcome as opposed to the surrogates of an overall level of experience and an overall level of outcome.
Right.
Okay.
Well, someone's used a medical terminology. The EHR is obviously the emergency room, but the PHR, I'm not quite sure.
If we can get a retweet in terms of what
Vanessa here has asked the question, how does EHR/PHR affect patient satisfaction? Is there any research you've seen in this space?
And this is where we need to pause and be honest, which is that that for Rick and I...
primary health. I suspect that may be primary health.
Primary health, right. So for Rick and I, we were not experts in the medical domain, and it's been incredibly informative for us to
humbling.
learn. And humbling. We've always been teamed with people who are MDs, who can give us the appropriate context. And so this is a great example of where we think Duke actually is different in its ability to bring people across disciplines and combine a research team that's drawn from the business domain, where Rick and I have many, many years of experience in looking at patient satisfaction more broadly, and then bringing experts in the medical domain together to tackle problems of fundamental importance. But as Rick said, it's been humbling.
Oh, personal health records. Oh, okay. Well, all right. So I guess I can answer that. The emergency room clearly is a place where wait times really count, and you can reduce or can increase patient satisfaction substantially by increasing the service rate. But having the personal health records there so that you can see what the patient's history is and more quickly diagnose what's going on and know what other medications that people are taking, whether they've come to the hospital emergency room a number of times before to get pain medication. There's some indication that people use the emergency rooms to get narcotic medication. Being able to have the personal health records electronically available is going to greatly increase the ability to service people quickly, get them in and out of emergency rooms, and that will certainly increase patient satisfaction, because we know patient satisfaction is really strongly associated with wait times in the emergency room.
Yeah. So the whole idea of a personal health record is incredibly powerful, and so coming back to the example of being approached by the colorectal surgeon, the comment was made: the data as of now have been distributed over so many different domains that in order to get a comprehensive perspective on the patient's experience, it was very difficult to assemble that information. Now, since then, there's been a migration into a personal health record, which I think actually does two things. It first of all, as Rick said, having that information should greatly enhance the quality of this co-production, because you don't have to rely on fallible information in terms of the patient recalling information and giving that to the physician or the nurse in their interactions. Instead, there should be a complete record, and so that you should have a higher quality of the co-production in terms of the information flows between the patient and the patient's previous experiences and the caregiving team. And so we think it certainly, the intuition is it should positively affect patient satisfaction. But the other thing it's going to affect is our ability to actually study how these experiences do connect to different outcomes, and to be able to have that comprehensive perspective, I think, again, should lead to the ability to generate insights around what is deterministic or diagnostic in the healthcare delivery process, in a way that we can simultaneously increase quality and reduce costs, which is enormously important in this area.
And just one side note, and I'm certainly not an expert on this, but the doctors now are spending a lot of time on the keyboard, or the nurses, pounding in information for these personal health records. Eventually, that technology will change, I think, to voice recognition, and get the doctor to be able to look at the patient and talk to the patient more, versus having their head down, pounding on the keyboard or looking up at the screen. So as we advance the technology, I think we're going to find that we're going to also increase the ability of the doctor or the nurse to talk to the patient, which we think is very important.
Okay, so a two-part question. The first one is much easier than the second. From Matthew Pritchard, who is daytime class of '09. And so the easy question is, have you published on the material you're covering today? And I guess that the only hard part of that is remembering the places where we have published. The answer is yes. The most recent article appeared in the New England Journal of Medicine. Some of this work has appeared in Circulation, the American Journal of Managed Care, and I'm forgetting about some of the other domains.
I don't remember either, but if the people who are interested, if you put in Google Scholar, put in Boulding, Staelin, and Klickman, at least, those three, you will come up with all of the papers that we published.
And we should give a shout out to our colleague Seth Glickman, who is an HSM graduate from Fuqua, also an MD, and it's been fantastic working with Seth and making sure that we don't embarrass ourselves working in this domain. The harder part of the question for Matthew is that the office in Massachusetts, in particular, the Office of Health and Human Services, are determining what objective measures they would include in outcomes tracking, and are assessing the role of patient satisfaction within these outcomes. And the specific domain is human service providers serving families involved with child welfare. And so the question is, any academic perspectives you could offer on this would be greatly appreciated.
You're looking to me?
I'm looking right at you, Rick.
Well, in a way, we don't think of patient satisfaction as an outcome measure as much as a fallible measure of the total quality being provided by the hospital or the service provider. With that said, it would seem to me that if you're providing service to younger people, you want to survey not only the children, but also the patient, the parents. And I think both of those would be indications of the quality of services being provided. But again, I don't think this is a measure of the outcome as much as a measure of the process that's going to lead to the outcome. So we're not saying that the best thing for the hospital to do or the medical profession is to make happy patients. We're saying what we want to do is capture what is being provided, the service being provided, and one measure is what the patients say about their experience.
Right. So you have us, Matthew, clearly in the area of speculation here, but I would think that a large part of the way that you're going to be tracking things here is to what extent you get compliance with the recommended course of action in thinking through the child welfare activities. And I suspect that that's a potentially large issue. And the more you have people engaged and understanding and aware of the value of those activities, then my guess is that the higher rates of compliance you might have. And so my instinct is that you would be thinking about compliance outcomes and then downstream outcome measures, and then some upstream measures that do capture the extent to which people feel like they received appropriate information about the process. And one of the things that we found to be very diagnostic in terms of patient-centered information is outpatient counseling.
Right.
In terms of when you'll see, specifically, I think we were looking at that when we were looking at readmission rates.
Yeah. But specifically, we found that when we're trying to estimate readmission rates, that a very good predictor of lowering readmission rates was having better patient satisfaction with the discharge instructions. So there are specific questions that said, are you happy or satisfied with the discharge instructions that you got? If we got affirmative to that question, we found that the hospital in general had lower readmission rates. So following up then, you could have questions like that if you're worried about compliance in the child welfare situation.
So the next question is from Jean Garner, and what Jean says is, in my research, I found that physicians fall in two camps: those finding PRO meaningful and significant, and those that discount. And so,
patients, I don't know what PRO stands for.
It's pro, and I'm for it. So again, if we can get a follow-up around what the PRO stands for, Rick and I are hopeless with these acronyms.
Patient record? I don't know.
So I guess that we'll find out what the PRO stands for, but I think that what I would comment, regardless of what it stands for, is that that for us, one of the most important things is that if you do have a view that there are people who fall in these camps that are kind of, they believe in something and they support it, and then there are others who may not believe in it, may not support it, that we have a critical function to play, which is we need to produce the scientific evidence that allows people to make informed judgments about patient-reported outcomes. Okay, so yes, so patient-reported outcomes, meaningful and significant, and those that discount. And so I think what Rick and I think matters a lot is that if you control for clinical performance and adherence to evidence-based standards, even after you control for that, which I think the physician community does believe in very much, that there is still a significant role for this patient-centered information. And I think that part of the difficulty in getting the physician community to accept that is a misunderstanding around what it is the patients know. And it's not that the patients understand how a physician should do his or her job better than the physician, him or herself. It's that the patient actually is involved in this co-production. And the more the patient feels like they're an effective part of that process, what we found is the better the outcomes. And so our hope is that we're going to shift the argument or the discussion from, it's not that patients know better, it's that patients know important things and that we want to get those into the healthcare delivery process.
And our measures of patient outcome are very objective. There's mortality and readmission rate. They're not what the patient reports. There is some research where the research is based upon what the patient says happened, and that's more tenuous. And we've never used those measures. We always use objective measures of outcome.
Right. So I think that brings us to the end of our questions. Any new tweets coming in? All right.
Oh, we have two more. Okay.
Okay, so the first question is, don't you see that speech recognition could actually provide the patient feedback? And so to kind of elaborate on that, my assumption is that in addition to collecting information that is scale-based around certain predetermined items to measure the patient experience, that you could use open-ended qualitative feedback from the patient. And this is actually a very exciting opportunity where the trick here is, when you're dealing with open-ended feedback, is that you have to construct something that makes sense of that open-ended feedback in a way that does two things. One, it flags the information so you can act on it for an individual patient, which is again getting back to the idea that we want patient-specific information connected to their medical experience. But also, you'd like to be able to create general insights by bringing the information together. And so you need to think through. It becomes kind of a keyword search,
right.
And you need to work with that enough that you can use advances in on the computer sciences side to use that information. But we think that's a very exciting opportunity.
Yeah, just as a follow-up on that, the Biveris experience, and I'm not plugging them, but I've seen some of their data. They have a place where the patient can provide feedback through a text message. Excuse me. And they find 1 or 2 or 3 cases a day where they're alerted to some situation which is quite serious, and they can take action right away. So the patients are using this as a way of telling somebody that they're in problems. Excuse me. This is particularly true for patients who go to the ER and are admitted into the hospital. And this is a way of communicating, and they've found it being very useful.
Okay, so there's still more. This is a very high-tech process where we're handed these questions. Okay, so this is from Elizabeth Dunbar. Only if we have an integrated electronic health record which is not system dependent, i.e. siloed within UNC or within Duke, for example, with no interconnectivity, will we be, as physicians, truly able to utilize patients' information in an integrated fashion? And this is, this is absolutely true, and it's one of the big issues that's confronting the implementation of electronic health records, which is you have providers who have an interest in having a proprietary system, and you have health systems that invariably move to something that they feel is customized and more unique. And what that does is it eliminates your ability to go across systems, across institutions, and if you hit that, then you're back to the old paper method. And so this is an area that I think has a lot of attention, from people, I think there's going to be a significant push to get this kind of integration.
So Elizabeth follows up with another question here.
Okay, so then Elizabeth has a follow-up question. Curious about your comments regarding how patient satisfaction relates to over-testing and the risks therein, and the recent Forbes article relating to same, indicating that satisfaction does not unequivocally mean quality. So this is actually very interesting. The Forbes article came out. For those of you who did not see this article, it essentially was an article that said that listening to patients is a very dangerous thing, because if you do, that what's going to happen is that you will over-test and over-prescribe, because the way to have happy patients is to deliver all of these services to them, and so that was and if you read the article and then you read the comments, there were a huge number of comments that followed saying, let me give you an example of why I think this is true. And tucked into those comments was one person that said, well, people might want to look at this New England Journal of Medicine article that actually addresses this and finds that there is a positive role for patient satisfaction. And in that New England Journal article, we had actually addressed this counter view that was picked up in the Forbes article, and our belief about why the patient information is of value. So, Rick, do you want to talk a little bit more about why we aren't jumping on this bandwagon of that I think the article was something like paying attention to patients can be bad for your health, something like
Right.
that.
Yeah, it's based upon two things. One, just a belief. There's no documentation on it, just a belief that patients ask for things, and if the doctor turns them away and says, I will not prescribe this medicine for you, that they're going to be unhappy and give lower satisfaction scores. And there's also a research paper by a man named Fenton, which has some data to support the contention that satisfied patients are ones that are have higher costs and are being overprescribed. We looked at that research and don't believe that it is as valid as other studies, and so we don't support that finding. But this is a good example where people have a belief structure about some phenomena that's not really backed up by a lot of strong research findings. And there are a number of studies that show that satisfaction is not tied to costs, namely that satisfied patients have higher cost of medical care. Now, there are some people, especially go to the ER, and we're aware of this, looking for pain medication. And if they're turned away, they may, in fact, be, quote, dissatisfied. But that's an area where you want a dissatisfied customer. You do not want somebody asking for pain medication when they don't need it. So it doesn't mean that a doctor or a staff person is necessarily going to be scored just on the score. You want to look at all the circumstances. Maybe a stupid analogy, but one we can all talk about is, we have teachers that are really tough and grade hard, and we have teachers that are softer and play to the students. We find empirically that those really tough teachers get very high ratings if they deliver a good service. And those that kind of kowtow to the students and don't give much information don't get high ratings.
Yeah. So the one kind of cautionary note that I would sound is that we don't want to overclaim, and so we are not physicians, and we don't have experience in different clinical domains where there may be information that suggests this very a perverse relationship between patient satisfaction and actually delivering higher costs and lower quality care. That we've looked at heart attack, heart failure, and pneumonia, and so we can say with confidence that in those domains that we don't find this reverse effect. But it's clear that that this is, I mean, one of the reasons why Rick and I are working in this area is there's a lot of controversy here, and therefore there's a lot to be gained by bringing insight to these issues. The follow-up from Elizabeth is she also wonders about the interplay between satisfaction and risk management, liability, and reform. And I have to be honest that I don't that our research has not touched any of those issues. We have looked at the relationship with the overall financial health of the organization and the connection between clinical outcomes, patient satisfaction, and financial health, but we have not gotten into the domain of risk management and liability issues.
No. The issue of reform, in some sense, we have a policy implications of our research, which are that if the administrators pay attention to the satisfaction data that they get and to look at trends over time of what departments or what service providers are lagging on those dimensions and then manage to that, that should increase the quality, the actual quality of the service provision. And that's because our belief is that that measure of patient satisfaction is actually capturing what's going on in the hospital. And again, Bill used the example of clowns and balloons, etc. We're not talking about having people be, quote, satisfied like in Disney World. We're talking about satisfaction with the provision of the service, and that patients seem to be able to capture what's going on in the hospital. They can intuit whether or not they're getting good service, and that's because they're feeding off dimensions that are not captured with the objective measures.
Okay, so we're, I think, ready to wrap it up. We've had some fantastic questions, some of which we've clearly stumbled, but many thanks again to all of you for joining us for this talk. I want to tee up the next session with two of our great faculty presenters. You're going to hear from Bill Mayu and Mohan Venkatashalam, better known to many of you as Dr. V, given the difficulty of pronouncing his last name. But I look forward to Bill and Mohan joining you and others in June. So again, many thanks, and we look forward to continued interaction with you.